now. Now it's time for the Ophthaeva Oration. Well, we have for our oration Dr. Vaishali Vasavada with us. A big round of applause for her. She's currently the director at Raghudeep Eye Hospital, Jaipur in Ahmedabad. Having finished her MS Ophthalmology at the M&J Western Regional Institute of Ophthalmology, Ahmedabad, she went on to do a phaco fellowship at Raghudeep Hospital and subsequently at the Moran Eye Hospital, Salt Lake City, USA. Her area of expertise is in the management of complicated cases of adult and pediatric cataract. She has a special interest in clinical research related to cataracts. She has more than 30 peer-reviewed publications in national and international journals. She has also made several scientific presentations in the international and national meetings and invited as a faculty in instruction courses and wet lab skill transfer sessions at several meetings, including the Asia Pacific Society of Cataract and Refractive Surgeon, the ASCRS, and the Organizational Development course at Bangladesh Eye Hospital, Dhaka. She's a reviewer of peer-reviewed journals, including the Journal of Cataract and Refractive Surgery and Eye. Dr. Vasavada is a member of AIOS, Gujarat Ophthalmic Society, Rajasthan Ophthalmic Society, as well as the American Society of Cataract and Refractive Surgeries. She has received several awards, including the Sante Vision for Paper, Best Paper Cataract at the annual meeting of AIOS 2010, the Best Paper Presentation at 2010, 2012, 2014 meetings of the ASCRS, Best Video Presentation in category at the ASCRS meeting in 2014, and the Best Paper for Pediatric category in the ARS, ASCRS, and the APACRS meetings. Dr. Vaishali Vasavada, we are overwhelmed to invite you, madam. Please come forth. We also call forward our chairpersons for the oration session. Calling forward Dr. Devdash Mukherjee and Dr. Ratish Chandra Paul, sir. Sir, please come forward to the front desk and help us with the medal, the flowers. Dr. Devdash Mukherjee, sir, please come. Over to you, madam. She'll be speaking on optimizing the right refractive solution for your cataract patients.
So while we are setting up, I think I feel immense gratitude, and I'm really, really humbled and honored to be here presenting this Ophthaeva Oration. And again, I cannot thank enough my dear friend Dr. Swati, and it's really my privilege to receive the plaque and the kind welcome from Dr. Mukherjee sir, Dr. R.C. Paul sir, and so many of my teachers are also sitting here. So this is indeed a very humbling moment. And I think when somebody starts calling you madam, you must get the right indications. So having said that, this is, I must, before we start, I do receive occasional research support grant from Alcon Laboratories. But I think we all are looking for, and this is a time when we don't really have a choice. It is very important to give an extremely good refractive result to your cataract patient in today's date and time. And this image I generated using the ChatGPT, the AI software. The whole idea of using this image is that maybe one day, today we are all discussing what we should do and how we should do. Maybe one day and very shortly in the future, we will have something where we just put in the patient data and AI will give you the right refractive solution for your patient. And because that's the way we are moving. So let's move on. I think, again, these are all AI generated images, more of I'm just trying to learn AI a little bit also. And I think the whole idea is that we are all in today's date and time, whether for entertainment, whether for work, we are always on one screen or the other and from screen to screen. And then intermediate vision with screens is a problem. Near vision is always a problem after 40, 45. And then there are other daily activities which are hampered and which nobody understands, that you can't apply a liner with your glasses on and you can't see the liner once you are in that golden age bracket. And even the big shots, even Motabai from our good old land will need to use these aids when you are working. So let's understand what patients think, what laymen think. And this is a survey conducted by one of the IOL companies. I have no financial interest, but they sampled people on the streets and general population, where they looked at 400 plus individuals and they asked them questions related to cataract surgery awareness. So this is what came out from the data that they gathered, that people over 60 years of age who have cataracts, they do not want any interference in their daily activities. So that is very important to them. And very importantly, they don't want to lose their independence and their quality of life. So we might, contrary to what we think, it's just not the restoration of vision. Today, urban people above the age of 60 are looking for these as part of their cataract surgery solution. And a lot of these people indicated that near activities were very important to them, and not only that, they expect that the near activities are going to improve after cataract surgery. And I think this is not new to any one of us who has been a cataract surgeon. Patients come with nuclear sclerosis and they have excellent near vision, and after the surgery they are so disgruntled because they can't see anything up close anymore. So this is what we face more and more these days. And what is also very important that I found when I was going through this survey was that what is the preferred source of information regarding cataracts and cataract surgery choices that the patient will make. In India, this is data from India, about 250 eyes, 74% patients still depend on their ophthalmologist. So I think whatever the industry does or social media marketing, it is still our word that drives 2/3 of our patients, if not more, to make the right choice related to their surgery and related to their IOL choices. And all the other things, as you see, this survey was done in 2019, I think, so maybe it's changed a little bit, but still mostly 70 to 75% decisions are made based on our advice. So we need to be very confident about this. Again, across Asia Pacific, across India and Asia Pacific region, only 8.5% of all suitable patients receive what these company people call advanced technology lenses, but which could mean any kind of presbyopia correcting technology. But 82% did say that if they had an option, they would be interested. So the other lacuna or the other discrepancy is also in the awareness that we generate to our patients. And 94% of patients said that they wouldn't mind paying a little bit extra for an enhancing IOL or something that treats their presbyopia. Now, how much they would want to pay is a different aspect, but at least most patients are ready to understand that it comes at a price. So having this background in mind, let's move on to what we can do and how we can increase the scope of making our patients happy. One aspect is, of course, it's good for the practice, it is good for us, but I think it generally creates more positivity among patients, and they will get you more patients who are interested in this technology. Our basic problem today is whatever lens, whatever brand we see, there is a direct conflict between giving a good range of vision and the quality of vision. Any lens today, whether it's an EDOF, whether it's a trifocal, whether it's those segmental lenses, nothing typically gives you the same quality of vision that we are all used to with monofocal lenses. And that's a fact of optics, which we cannot change. But the good news today is that evolving over a lot many options, it started as monovision, we now have many options, and I think the most popularly used by most people today are the trifocal IOLs. And now the new range of EDOF IOLs and the monofocal or enhanced monofocal IOLs has added on to this cohort. So in my opinion, what I use and what I think most people across the globe prefer is trifocals as well as EDOFs and monofocal plus. But how do I choose? And how does it help me to expand the scope of my presbyopia correction during cataract surgery? And I think like I said, presbyopia correction should be taken very seriously, and a lot of us sitting here do experience that and understand that presbyopia can be really disabling. So you may not be able to treat it or eliminate it, but at least if you can increase some range of vision in any patient, they are going to thank you for that. For us, fortunately, gone are the days when there used to be these big conferences on who is a good patient for a bifocal, those +3, +4 kind of diffractive IOLs, where hyperopes and unfortunately homemakers, women were supposed to be the ideal candidates. So the things have evolved a lot. And now with trifocal lenses, I think what we are seeing in our clinics is that the talking time or the convincing time where you have to talk about so many negatives and be aware of this and that is going down drastically, and the number of people who are opting for these diffractive or trifocal lenses is really, really going up, whether they are professionals, whether they are homemakers, retired, young. And unfortunately, after COVID, I don't know what you feel, but we are seeing so many more younger cataracts. In fact, I was analyzing our data over the last 3 months from people who are undergoing cataract surgery, and about 40 to 50%, if not more, are below the age of 50, not only 60. So things are changing drastically in terms of the demographics. Why we are more confident now with trifocal lenses? Because all the brands, whatever trifocal lenses are available across the platforms, have a very good light energy distribution. The wastage of light that used to be 18 to 20% in any kind of diffractive lens has come down much more. And because they have better optical designs, the steps and the gradations have improved a lot. They give a very good overall performance, with the good part being that the dysphotopsia and the glare, the halos are much more acceptable. I wouldn't say they are gone, they are still there, but they are very, very acceptable. So I think for us, the trifocal IOL works in anybody who comes to you. If a person says that I don't want to wear glasses, then I still believe that in today's technology, the diffractive trifocals are the best, because these are the ones that give you the greatest amount of spectacle independence and a really good range of vision. But what are the little trade-offs? I think that main 2 trade-offs, in my opinion, one is the night driving glare, and if you are somebody who has to drive in an environment where there are not many dividers on the roads are not lit, that's the kind of population who are going to be affected. Somebody who's very fastidious with the sharpness of their vision. People don't talk about this much, but I think all of us who use trifocals have noticed any kind of diffractive IOLs, that sometimes that little waxiness or the fact that they don't really enjoy the vision, even the distance vision, these are the 2 main issues. And this also came up, the dysphotopsia was the #1 reason why surgeons hesitate to implant multifocal IOLs in a survey by the American Society of Cataract and Refractive Surgeons. So I think this is a little drawback, but for most of us who drive within the city during night or are not very, very hard bent upon doing long distance night driving themselves, trifocals are a great option. Now moving on to what if you don't want to risk the trifocal IOL, or if the patient profile is such that maybe they are somebody who has a lot of stage presence, somebody who works in a lot of bright lights, or their profession demands extremely crisp vision at all distances, then I think that's where the entry of the EDOF IOLs has really expanded the spectrum of people who can have presbyopia correction. The best part with EDOFs, a lot of them, not all of them, is that if it is not a diffractive EDOF, if it does not have rings, you don't get the problems of rings, which is typically night driving issues. So EDOF IOLs, like I said, are of 2 types. Diffractive, which was the original, the Symphony lens that came in, which was a great lens, and had probably started this whole revolution of giving a more extended range of vision. But being diffractive in its optic design, it fell out of vogue slowly because of the inherent problems that any diffractive can have. So the whole market is now gearing up for non-diffractive technology, EDOF, or what is more common also now, monofocal plus, which give a little additional but not really a good full range of vision. So how does an EDOF technology differ from trifocal? These are non-diffractive, therefore there is no splitting of light into distinct foci, Instead, there is usually more smooth redistribution of light, and therefore the quality of vision is much better, and we'll discuss what is the cost. I am used to this IOL, so I can talk more about this IOL, and I'm not saying that the other IOLs are not good, but this is I would say not so new Vivity IOL, which again still has some surface transition, but there are no rings. So because of that, what it actually does is it stretches this light into a more continuous focus rather than having 3 focal points that you see in the trifocal lens. But we must understand that there still is some surface modulation in order to give us this extended range of vision. So then what is the negative or what is the drawback of using an EDOF IOL? It is most patients, I would say at least 8 out of 10 patients will need reading glasses for fine print. And when I say reading, it is not only books, even for cell phones for fine print, they do need anywhere between 0.75 to 1.5. But in our experience, most of them are okay with 0.75 or 1. And like with any other presbyopia correcting IOL, there is some loss of contrast in dim light. So like I started off with, there is nothing which is as good as a monofocal IOL in every aspect, but this appears to be very close with that limitation of a fine reader. And how does now EDOF fit into our practice, considering that there are now 2-3 options? So I think just like trifocal IOLs, healthy eyes are still the best candidates for any form of presbyopia correction. And let's move on to the next segment of my talk, which will talk about how do you decide for any kind of refractive solution which includes astigmatism, which includes presbyopia correction, and which includes quality of vision. So I think monofocal IOL still is a very integral part of a good refractive cataract surgery. There are patients who will do best only with those IOLs. In any case, the first and foremost thing is to get good preoperative data. And just a couple of things I want to highlight is the ocular surface. Now I understand that in our busy practices, none of us really does the Shermers, or every patient you won't be doing the tear film breakup time also. But I think now the new devices or instruments also help us. Like for example, I have taken this picture from Placido topography, which comes with the abrometer, but any kind of Placido topography or an optical automated biometer, when you take the image, if the dots or the rings are not completely regular, as you can see here, this is a pointer to you. And how do we don't do this test ourselves in our clinics. So the very important thing is to train your technicians and optometrists to understand what is the interpretation of these kind of readings. Because if they don't understand, they will just give you the readings, a printout of the reading, and you will go wrong in your judgment. So here is an example of a topography captured after an applanation IOP was done, and you can see the Ks are about 42.1 and 42.07, but you can see the irregularity in the Myers in this inferior region. The same topography which was captured after putting a lubricant and making the patient wait in the clinic for 15 minutes after that, the topography from 42 has gone to about 45. So not only your presbyopia correction, even your spherical IOL calculation is going to go completely haywire. And like I said, that's also a very important part of giving a good refractive outcome. So dry eye not only changes your selection of yes multifocal or no multifocal, but in my opinion, the most important thing it does is unreliable biometry. Again, here I have put in 2 printouts. The same patient on the left is something that we took, and this is a patient planned for a monofocal lens. Now here you see the K1, K2, 41.12 and 42.9, and the spherical IOL power would be about 21 diopters for a regular monofocal. Now we realized that this patient has a dry eye and treated the patient and a repeat biometry on the same machine. And if you see, this is way back in 2016, the spherical IOL power jumped 1 diopter from 21 diopter to a 20 diopter. So my point is that ocular surface needs evaluation. If not anything, at least look at the patient's Myers at whatever instrument they are being evaluated, or put a drop of fluorescein and see. The next thing I wanted to highlight when we say optimizing the right refractive surgery or the right refractive IOL is, I think, the amount and the type of astigmatism which is going to make or break the deal. We see so many patients who have had excellent surgeries, pristine eyes, multifocal lenses put very well, but they still need glasses because they are left behind with a 1 or 1.25 diopters of astigmatism. So we do need to evaluate. I'm not saying that everybody should do a topography for every eye, but as we move on, probably when you are thinking of the next upgrade or next investment, some form of corneal topography really increases your confidence in using these kind of refractive solutions in the patient, because uncorrected astigmatism is shown to be the #1 cause of dissatisfaction following multifocal lens implantation. Now, which formula should you use? We must all be thankful to Dr. Graham Barrett and Dr. Warren Hill, who have put out these excellent formulae free of cost on the APACRS website or on their own website. What we like to do as a standard for any short eye, long eye, average eye, we are using the Barrett Universal 2 formula, which in a lot of the new optical or OCT based biometers is inbuilt. But even if you don't have that, you can always do a good immersion and go online and calculate your IOL power using the Barrett Universal 2 formula. So that's point number 3. Point number 4, for optimizing the refractive solution, I think more and more what we found from few years back, we did a study and we reported this in the American Journal, is the role of OCT in every cataract patient. Now, these kind of changes, when you have a fine epiretinal membrane or a vitreomacular traction, these are the things that you will never see. Even a trained retina specialist cannot see them in the presence of a cataract. So if you are in a practice where you have a retinal surgeon and the OCT is accessible to you, I think every patient should undergo an OCT, but at least those who are planning, let's say they have already agreed for a multifocal or a toric or an EDOF lens. If you did not do an OCT, please put them through the OCT so that if you have to revert the decision, you can do it before the surgery rather than trying to explain it to them post-operatively. In fact, I want to tell you one of my own personal experiences. This is from 6 months back. We did a brunescent cataract where the OCT could not, it was a very hazy capture, and this lady underwent a toric monofocal IOL implantation. Post-operatively, she was found to have a foveal burn, eclipse burn on the OCT, and this patient actually filed an FIR on me. The police one day turned up in my clinic saying that she's not happy and you didn't do the good job. Fortunately, we had a pre-operative OCT where we could show that it is very hazy and you cannot make out, and the post-operative OCT, which I like to do for any patient who seems to be a little unhappy, even though the vision was 6/9. So times are changing, and any technology that can help you document and also show to the patient, I think even in that aspect legally, it is a good thing to be safe and to be able to show that this is not my fault, this is what is there in your eye just before surgery, so you stay away from this lens or have a reasonable expectation. And point number 5, we have to spend more and more time with these patients, and I think that's becoming a reality of our practice, that gone are the days when you just give a prescription or a recommendation and say that, okay, now my resident will take care, or my optometrist or my staff will do the rest for you. The key points, especially in choosing the lens, have to be discussed by the surgeon. I think that makes it much more smooth sailing even in the post-operative period. So I always make sure that I discuss the lens, and when I'm explaining to them about a laser or a phaco cataract surgery. So these are the 2 points all surgeons at our centers do explain personally, in spite of them having undergone a very extensive counseling. And sometimes we might change their opinion after this. We might want to push them in steer them away from a certain direction if you find that they are not really very accepting of any negatives that the technology might have. Most important that I have realized over these many years is that if the team does not show the same amount of confidence and body language in any technology, that be it contact lens, be it your medicine, be it your surgery, if that does not reflect in their body language, then patient is likely to be a little shaken, will take another opinion, or will not go for that option that you have suggested. So time to time training your staff and particularly even the receptionists, because patients are going to interact with them pre and post-op, and they need to be very confident and positive. Show them the results. Show them that, see, this is what this person came with, and look what he or she is doing today, and why he or she did so well after cataract surgery. Now let's go on to some real life cases. Now this is an actual case of a 60-year-old practicing, operating ophthalmic surgeon who came with bilateral cataracts, and there is borderline astigmatism, but otherwise the ocular profile is suitable for trifocal. Now this surgeon himself did not implant multifocals in his practice, but he has seen so many patients with trifocals, and he feels that, no, I think looking at the satisfaction I see in my patients who come from other places, I think I will be very, very motivated, and I am a good candidate for trifocal lenses. Now this was our first experience with an active ophthalmologist, and we tried to demotivate by saying, you'll have glare and you might have halos, and operating the fine focus and all that. But the patient said, don't worry, let's do one eye and then we'll think about the other eye. And after all that, the surgeon underwent trifocal toric because it was 0.6 diopters of astigmatism. Technically, things went okay, fortunately. And then binocular toric trifocals, and the surgeon is very happy. And the surgeon says that I would recommend other surgeons who may need cataract surgery at any point, you can go for trifocals. So I think the other good part also with all these technologies is that when we operate in the microscope, it is our distance vision that comes into play. So I think that should not be an issue. But yeah, not every ophthalmologist will accept this. And subsequently, we now have 3 surgeons who have undergone trifocal lenses. Another challenging case of a 42-year-old lawyer who has had familial nystagmus. He knows that. He has come with bilateral posterior subcapsular cataracts and is very insistent upon not wearing glasses. Now this patient, I explained to him an EDOF, and I said, that's the maximum we can do for you, and you should be okay with wearing a pair of glasses. And he went away after the pre-op. He said, let me think about it. He came back to us twice after that, and he said, don't worry, doctor, I am vouching for it, and I want to undergo a trifocal lens, because he read about it and he doesn't want to wear glasses. So this is where the patient actually demanded out of us, and this is an actual, I don't know whether you can see this, the rings, and this is the nystagmus that the patient had, bilateral. And to our surprise, and fortunately his binocular unaided vision is 6.9, near vision is N6, and he has absolutely no complaints. He's an active practicing lawyer, and just to show that this is not all theory, patient may say anything. This is a contrast sensitivity charting of the same patient done, and age appropriate, this gray zone is the region where his contrast should be. So without and with glare, even in the mesopic conditions, on this slide you see, even in the dark lighting conditions he's doing quite okay. So his contrast sensitivity is also very good. I'm not saying that every nystagmus patient should get a trifocal, but times are changing and we need to be more accepting, provided we have enough experience and provided we do a good pre-operative workup. So I think if the patient understands the limitation of their eyes in several cases and of the technology that is there today, the motivation will drive them to do anything. It's like the corneal refractive surgery. So many patients will take a trade-off of dry eyes or a little glare for their glasses independence. Another case of a 56-year-old male who has to drive a lot, 30 kilometers, his factory is outside the city. He has always been a myope, and because of the cataracts has had to give up night driving and doesn't enjoy doing carpooling. So this is a patient where he's young and he wants to drive, he needs to drive at night, and glare at night has been the reason why he has come to us. So this is one patient where we would suggest a bilateral EDOF IOL and target emetropia, so that he gets good distance vision without any negatives of glare and halos. But we do need to tell him that you will need glasses for fine print, which will be definitely much less, at least 50% of the prescription power compared to a monofocal. Now there is a school of thought who says that if you're wearing a reader, whether you wear 2.5 or you wear 1.25, how does it matter? I think a lot of us here can vouch for it that it matters. To be able to see something grossly and to be completely blinded without a pair of glasses is also a huge difference in life and in the way you feel confident about doing activities. So I think this patient was very happy. And as you can see, the greatest thing about non-diffractive EDOF, I find, is that the distance vision is never a problem. And out of these so many IOLs, we have only had one patient who has complained of dysphotopsia at night. Now, that could be some factor related to the patient's eye or their retinal sensitivity, but the IOL itself gives excellent results. Typically, we like to target emetropia in both eyes. You could do a little bit 0.5 diopters of mini monovision, but even that cannot eliminate the need of a small reader, is what I would like to say. And I think we should be very open about it. Whatever anybody tells you that VVT lenses I put and I don't need any reading glasses, in good light and with an enlarged font, yes, you will be okay. But if you really want a smooth, long-term reading, most patients do require a small reader. And like I said, this patient has accepted 1.25 diopter glasses, which he uses only selectively when he cross-checks his bills and his accounts. Now, this is another case of a young patient, a 29-year-old male treated with steroids for skin allergies and comes with bilateral cataracts. And like you would see with a lot of these atopic patients, this is a kind of a form fruste keratoconus that you see on topography. But I want you to focus on this black circle here. This is the pupil size in mesopic conditions. So one more thing I find very useful is that whenever you are capturing any kind of topography, which most of these have a pupil size or a pupil aperture that they will denote, and do these with the room lights off. So that will be a good mesopic pupil size for you to figure out. And like I said, in the mesopic pupil, the astigmatism is regular. It's almost regular. So we went ahead and did a bilateral VVT toric IOL, and this is what you can see 2 weeks post-op. There is a little bit of a posterior capsule plaque, and he has been counseled that you may need a YAG, but the eye is doing very well, and his vision is 6/9 plano. Now with a form fruste keratoconus, not every eye will get a 6/6. That's another reality of life, and not every eye needs a 6/6. So this patient is N6 parts at 66 centimeters and N6 with only a 0.75 diopter add, and he's very happy with his EDOFs. And I think this will be my last case. This is again a maxillofacial surgeon, and along with having bilateral posterior polar cataracts, he's also a national level table tennis player. He doesn't like wearing glasses. Everything, the eye looks okay. All the parameters are okay. So we were a little skeptical about trifocal lenses, and again we pushed him for an EDOF IOL. He's very happy with distance intermediate, but now when he came, he says, can't you do something when you do my other eye? This is a posterior polar cataract, second eye he's planning. So he wants better near vision. And therefore we did VVT IOL in one eye and a trifocal toric in the other eye. So binocularly he's N6 at intermediate and near, and because one eye is excellent for distance, he's very, very happy with the quality of vision, even for distance and for driving, and his dental chair. So the point is, trifocal IOLs are very successful even in active and professional individuals, yet they cannot be for everybody. The patient should have a reasonable kind of expectation or understanding, and then you'll be very happy with those. I think now with the EDOFs coming in, there are other situations such as these, and we are doing a study on early macular degeneration and EDOF lenses. Very clean-cut, 4-cut RKs. For example, this is a physician with a 4-cut RK who was very happy with the bilateral VVT, Fuchs dystrophy, or a very, very early sort of stable glaucoma. But in the end, while we all want to give better refractive outcomes to our patients, better quality of vision and make their lifestyles better, if the patient is not motivated, I think the story ends there. We should not be trying to sell a product or an IOL to a patient, because that's not what our job is. Anything where there are significant higher order aberrations or a little fine opacity or an irregular corneal astigmatism and a significant ocular comorbidity, like I said, a well-done monofocal IOL is still a very good refractive cataract surgery even today. So I think with that I come to the end of my talk, and let me take this opportunity to invite all of you to Ahmedabad for our annual cataract workshop. And we are very happy, and I think you will enjoy Dr. Michael Lawless from Australia, who's an expert at all refractive surgeries, who's going to be our star faculty. Again, thank you very much, and I really feel humbled and privileged to be here. Thank you.
Thank you so much. A big round of applause for you, madam. Dr. Devdash Mukherjee, sir. Sir, what is your take on this?
I would say, rather advise, because I am very senior, to all the Ophthaevas that are present here, take her all points in your heart and translate in practice so that you will be better. The last point she said, that don't sell the product. It is tailor-made. Ask the patient's need, ask about his pocket size, then you decide. And for the decision making, you must go through the protocols or the SOP. See pointed over here. An excellent presentation, even at my age of 68. I have few more points to take home and practice a little bit in my residual life.
Thank you.
Thank
sir.
you.
Thank you.
Would call Devdash Mukherjee, sir, and RC Paul, sir, on the stage for a gift from madam. He's currently the president of OSWB. For their presence itself is a motivation for us. These are some sweets from Bengal.
Oh, thank you. I come
Now-
to Calcutta to eat mishti dahi and sandesh every time. Thank you.